of you may not have had as much exposure to them. So this is just to kind of get everybody up to speed for some of the things that we're going to expect of you, not only in your roles downrange, but in simulations here while we're in JECC. So let's review the TLO. Manage invasive monitoring devices to post-surgical patients during evacuation aboard rotary wing aircraft. Given a simulated en route care scenario and standard adjuncts of en route care, orchestrate the setup and management of invasive lines and operate invasive line management equipment as supported by the JTS CPGs and sister service protocols. So as we look at this administrative data, just please don't fall asleep while you're sitting in quarantine. That's pretty much where we're at with that. Okay. So here's our agenda. We will go over ART lines or invasive blood pressures, central venous lines, end-tidal CO2, pressure monitoring for your cranial patients, as well, as intra-abdominal pressure monitoring. Before we go into that, Captain Killen, can you give me one example of why we might want to do invasive monitoring for our patient?
Yes, ma'am. So there's still a lot of benefits to it, but getting the central venous pressure, just a lot of things that you can't see just by looking at a ZOL. Also, just a lot of diagnostic abilities that you would have normally in the ICU or ER that you need to have while you're en route.
Okay. Captain Wynn, what else can we do with invasive monitoring?
With invasive monitoring, you can also do your blood pressures. You can check your CVPs. I mean, if you have the ability to do things like that. We won't really have things to do like that, but you can do blood pressures. You can do, like it says, the intracranial pressures, but also if you have like a Foley that has a temperature, you can get good temperature checks, as well as abdominal pressures and things like that.
So you mentioned getting a blood pressure. What's the benefit to doing invasive monitoring over, let's say, our standard blood pressure?
It's slightly more accurate. So it can be more accurate in an ART line that's functioning well with a good waveform. It also, when you're doing a normal blood pressure, if there's any like edema, dependent edema, or like any edema within the arms, you might have, or the cuff's too big or the cuff's too small, there's too many vibrations, or they're moving their arm, you can get a very inaccurate reading. So sometimes the blood pressure readings from an ART line can be more accurate and give you a better like minute to minute of what's happening consistently with the patient.
And that's kind of where I was going with that, where we might have to wait for that blood pressure cuff to cycle, and then depending on how low the blood pressure is, it may not register. Invasive devices can give us very accurate, up-to-date information that we don't have to wait as long for. Staff Sergeant Dumont, anything else you want to add?
Not really. I mean, she pretty much covered the majority of it.
Okay, but for any other reasons for invasive monitoring?
Other than it's a lot more accurate than, like she was saying, than doing like a blood pressure cuff, because it takes out the possibility of the cuff being too small or too big for a patient.
Okay. Some of the other things that I like to think about is the ability for us to identify problems much earlier for our patients than maybe we would see with some of the non-invasive or not as highly technical devices that we utilize in patient care, as well as seeing whether or not our patient is actually responding to the interventions that we're providing. Certainly, if we are giving blood or we're giving pain medication, we want to know if that intervention is successful. And likely, our patients can't talk to us. It's really hard to communicate in a helicopter as it is. And then, oh, by the way, we took their airway. So really looking for some additional information about the effectiveness of those interventions that we're actually conducting. So when we talk about these devices, it definitely facilitates early detection and identification of conditions, evaluates the effectiveness of what we're doing, evaluates the patient's response, and it gives us additional data points to add to our overall assessment. Now, having said this, everything that we do has a risk associated, and we must really take a step back and ensure that the risk associated with it is warranted based off of the predominance of benefit from having that intervention. risk-benefit analysis is critical. I know you guys have heard of Murphy's Law before. If it can go wrong, it will go wrong. And so we need to have those conversations well in advance to make sure that we are ready to respond. Having said that, if our patient is sick enough to have any of these devices, chances are they're sick enough to want to keep the device in once it's placed. And so we need to be particularly protective of it, especially when we start talking about packaging and how to successfully manage our patient. So ELOA, the big one that we're going to talk about first, is going to be the management of an arterial pressure monitor. Now, when we talk about placement, Captain Angelotti, give me a couple of different locations that we might be able to place an art line.
We could do a radial artery or femoral artery as well.
Okay, I like that. Captain Battles, can you give me any pros or cons for either one of them?
Radial might be the preferred spot, lower risk of infection. Femoral, it's nice, big, easy to get typically, but you do run a higher risk of infection. And then, you always have that third option, brachial. Less preferred just because location kind of get kinked. Sometimes it works great, sometimes it doesn't.
All right, great. Thanks, guys. So when we talk about placement, the radial artery is going to be the most commonly used site for cannulation. We've talked about that. Everybody right now in your rooms, go ahead and touch your radial pulse. Pretty simple, right? With this, what you just did is you demonstrated the fact that it's easy to access. Okay. There's another huge benefit to the radial artery that we don't necessarily see for the femoral and brachial sites. Major Manzo, do you know what that is?
Other than ease of access, no ma'am.
Okay. What's the test that we do, Major Manzo, before we place an arterial line in the radial site?
Is it Allen's sign? Because we check to make sure that the ulnar artery can still perfuse the hand if we were to get a clot in the radial.
Absolutely. So when we do that Allen's test, we're looking to see if when we occlude both the ulnar and radial arteries, if when we release pressure from that ulnar artery, if our palm is able to receive perfusion. We have what's known as a palmar arch, which connects those two systems, and that gives us collateral circulation. So in the event that a provider goes to place that line and they shred that radial artery, well, we still know that we're going to get perfusion to the hand and the fingers because of that collateral circulation. That's certainly one of the benefits. Captain Rosales, what else about the radial artery is nice, especially when we start talking about how easy it is to get to it?
Well, ma'am, from my experience, and this is all new to me, I haven't done ICU in a while, it's easy access, like you said. It's also beneficial for your blood pressures and drawing blood for your ABGs.
Okay. When you talk about the ease of access, does that also mean that it's easy to apply pressure to?
Yes, ma'am.
Absolutely. So, guys, when we talk about these arterial catheters, hemorrhage is going to be a huge risk. And if for some reason we rip out our arterial line that's placed at that radial site, it's much easier to provide pressure and to stop that blood flow at that site, whereas something like our femoral artery, which is much larger, causes a little bit more of a challenge when it comes to stopping hemorrhage from that site. We briefly mentioned that the femoral and brachial arteries can also be used. Brachial, certainly a little bit easier to get to, not as easy necessarily as the radial, not as dirty as the femoral. Certainly in a code situation, that femoral site, though, is going to provide a larger vessel, which may be a little bit easier for us to access. But then, as previously mentioned, it is a less clean site. It does have a higher rate of infection at that site. So we need to keep that in mind once we get our patient through the initial resuscitation as far as looking for other sites to place an arterial line. Indication, patients requiring continuous hemodynamic monitoring as well as frequent ABG checks or labs. Now, we probably won't be doing that in route care. However, it is a factor. Has anybody ever been actually stuck for an ABG? I know it's extremely painful, and if you have to do it multiple times, your patient's going to thank you for actually placing a line so that they don't have to repeatedly get stuck. So it's something to think about. Less of an issue in our area, but nonetheless a benefit of having an arterial catheter. Now, here's a review of our waveform. This is just to kind of talk about the tie to the EKG. Sergeant Seidel, what is the EKG a representation of?
Just our basic EKG?
Yep. What does the EKG show us?
I mean, I don't know exactly what you're looking for. I mean, it's just the rhythm of the heart, systole, atrial opening, closing, ventricle opening, closing, that kind of.
Does it give us information on the electrical activity or the mechanical activity?
Electrical activity.
Absolutely. Thanks for that. And then Sergeant Yanez, when we talk about the EKG, what portion of the EKG represents the electrical activity that should stimulate a ventricular contraction?
I'm not too sure, ma'am, to be honest.
Okay. So when we look at the EKG, a QRS complex is going to give us an idea about ventricular activity. And so what you'll notice is as you look at this EKG, hopefully you guys can see my cursor, this QRS complex is the electrical stimulus that we would hopefully get a mechanical response from. Now, that mechanical response is actually seen here in the waveform on the art line. So you'll have an QRS complex, and then immediately thereafter, you'll have an uptick in your arterial pressure waveform that's going to give us an idea about the mechanical response of the heart to that electrical activity. Now, in our art line, we have a nice little piece here that's called the dichrotic notch. Captain Schuler, can you tell me what the dichrotic notch represents?
What the dichrotic notch is?
Yep.
That, if I remember correctly, that is the relaxation of the ventricle. So basically you have your arterial valves closing and your ventricle now squeezing, so the arch should be the relaxation. So it's kind of like that in between the beating of the compressions of the heart. It's the I feel like I'm just going in a circle here.
That's okay. Captain Angelotti, can you help him out a little bit?
Ma'am, my guess would be the repolarization. That seems to be correlating on the EKG with the dichrotic notch.
Okay, so when we have blood flow through the heart, that blood flow is mitigated or managed by pressure gradients. And our valves in our heart will open and close based off of those pressure changes. So when your ventricles squeeze that blood out, the valve that the blood has to flow to will eventually close to prevent backflow. In this scenario, we're actually looking at closure of the aortic valve. Okay? So as we see that aortic valve close, we'll have that notch, and then the pressure will fall off as the left ventricle continues to fill for the next cycle of our cardiac cycle. So when we talk about this, here's another example of what those arterial waveforms look like. This is kind of a different look at the waveform, but I have this here because I want to talk to you guys a little bit about calculating a MAP. Now, you'll see here that MAP is equal to systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. Major Rose, can you tell me which part of the cardiac cycle the heart spends the most time in?
Which part of the cardiac cycle the heart spends the most time in? Refilling.
Yes, absolutely. Refilling, that relaxation part, and out of systole and diastole, Major Rose, systolic blood pressure or diastolic blood pressure, which one represents that filling?
Diastolic.
Absolutely. So if we're going to spend more time in that diastolic phase, we are going to have to give more credit to that when we are calculating that MAP. So if you see the systolic plus 2 times systolic plus 2 times diastolic divided by 3, that's why that formula is developed like that. Now, you go, why do I care? I've got an awesome monitor. That monitor is going to calculate that for me. We're good. Yes, in general. However, we start talking about the prolonged field care environment, and we start talking about our monitors quitting and the things that we need to do. Now, certainly in the back of an aircraft, you're not going to be able to do this. However, in a prolonged field care environment, you may have to actually calculate that on your own. As long as you have a blood pressure cuff and a stethoscope, you can do that. You get your systole, you get your diastole, you do a little bit of math, and you can calculate your MAP. So just kind of keep that in mind that we need to maintain some of those basic techniques in order to ensure that we can provide the best care to our patient. Okay. So then anything that's got a pressure line to it, whether we're talking CVP, bladder pressures, or art lines, that transducer has to be leveled. Now with this, particularly for the cardiovascular system, we're going to level our transducers to phlebostatic access. Now with this, it's going to be the junction of the fourth intercostal space and the mid-axillary line. Now, Major Manzo, can you tell me a little bit about why we might want to level a transducer?
I mean, it needs to be leveled so it's getting an accurate pressure measurement. If it's too high or too low, it's going to impact your measures and your waveforms.
Absolutely. So when we level those transducers to different anatomic landmarks, it's so that we have an accurate reference point. If I were to take my transducer off of wherever it is secured to and drop it on the floor, that's going to affect my blood pressure. That's actually going to make my pressure significantly higher. For every inch that we are off of our anatomic location that we're supposed to be at, we can have about a 2 millimeter of mercury difference in that reading. And you go, oh, that's not that big of a deal. Well, if we're titrating our vasoactive medications, we really need to be sure that the information that we're getting is accurate, or we're treating an invalid data point. Okay, so this really comes into play. And then certainly if the transducer is higher, then that blood pressure would be lower. Okay. In addition to transducer leveling, we also need to zero it. We'll talk about it here in a second. And then our third piece is that we want to do what is called a fast flush test or a dynamic response testing, also square wave test. So it's three different things, but what we're doing is checking to see if we have an accurately damped art line tracing. So on our screen here, what you'll notice is that you have a couple of beats. And then what I'm going to do is I'm either going to pull the pigtail or squeeze the clamp. We'll show you that down at the DTC, and send some of that normal saline from that pressurized bag rushing out of the tip of that catheter. When we release that normal saline clamp and allow it to stop flushing, we should see oscillations here. Now, in this particular example, I have approximately 2 oscillations here. This is going to give me an accurate measure. It has that, we have a good dichrotic notch here in our waveform, and we see those oscillations here. So we're confident at this point that the numbers that we're getting are accurate. Now, we can have an issue with overdamping. With this, if we were in the classroom right now, I'd be speaking very, very quietly. I don't want to do that in this setting because you may not be able to hear me. However, with this, that signal is muted to some extent. It's quieted to some extent. So you'll see that our waveform doesn't look quite as pretty. It's significantly more rounded. We don't have that pretty dichrotic notch. And then when we look at our oscillations, we may not have any, or we may just have the one. And then we go back into our beat. Now with this, we need to start troubleshooting because it's going to impact our readings that we have, particularly when we start talking about the differences in systolic. And you can see in the picture here that our systolic would normally be higher than represented, but because of that dampened or that overdampened tracing, it's going to be lower. Now, troubleshooting for this is going to include things like blood clots, air bubbles in the tubing, as well as kink catheters. My ICU nurses will know that sometimes when we get these terrible waveforms, we start manipulating that wrist as we try to straighten out that catheter or get that catheter off of the side of our vessel wall. And so with this, the big one that I'm particularly concerned about is going to be those air bubbles. We've talked about air bubbles a little bit already and how something that is small on the ground when we get to elevation may expand. It's going to impact our reading for sure. Now, another thing that we can see is underdamping. Now, at this point, normally I would be screaming at you guys because what you can see with this is that waveform is super loud. Okay, we'll see these exaggerated peaks and really just kind of what looks like an angry waveform. And then when we do our dynamic response or our fast flush, what we'll notice is we have a wicked amount of oscillations here. Okay, now with this, we're going to have some alterations in our readings as well. The indications or the challenges with this that we may have or that may cause us to see this are going to be those long connecting lines or when the catheter occludes the vessel. I know for me that Sometimes when my patients have needed to go to the MRI, I'm going to put every bit of extension tubing on there so that we can have that extra length. Now, that's not real good when it comes to this situation, so we got to keep that in mind. We can also have a problem with it if the vessel that we've placed the catheter in is particularly small in relation to the size of the catheter itself. In that instance, we can't really do anything about it. We just have to troubleshoot. Now, this is going to bring me to make a point about trying to say that non-invasive blood pressure and invasive blood pressure readings are substitutes for each other. They are not. Okay, the science there on getting a non-invasive pressure versus an invasive pressure is completely different. You can't necessarily substitute one for the other. However, it is a good idea when you first start out and you're doing your assessment to compare your non-invasive blood pressure to that invasive line, just so you can kind of get an idea. Just be cautious with using those numbers interchangeably. Okay, we have some arterial catheter measurements here. This is just kind of an overview with the systolic and diastolic pressure and then the map here. Now, this slide really gives me an opportunity to talk to you guys about doing some trending for your patients. Mr. Dipple has mentioned this previously, as well as some of the other instructors, when we start talking about the 10% rule. That 10% rule, we need to, upon our initial assessment, get an idea of what the patient's current vital signs are. Now, if there's an increase or a decrease in those vital signs by 10%, we need to start looking for a reason. So if my patient's heart rate increases by 10% and I didn't do anything to cause that, I probably need to start looking for something and doing a little bit of a deeper dive into my assessment so that I can provide an intervention. If we fail to notice those trends early, we can get very far behind the power curve, and then it's just a bad day for all of us as we kind of chase our tail to get right with what our patient needs. So I'm going to strongly encourage you guys, as you move into simulation and are downrange completing this mission, to consider your baseline vital signs and what a 10% change is, and then having that troubleshooting conversation with your partner to determine, hey, if this happens, then we're going to do this. This is what I would suspect. Okay. So some pressure monitoring complications, certainly exsanguination, fancy word for bleeding. We've talked about that. With this, anything that can get caught on a litter stanchion, a part of your uniform, anything about that in the environment, it will. So packaging is going to be huge, because if these lines get pulled, you're going to have a problem with bleeding. Thrombus formation, hopefully we don't have as much of a problem with that in our environments. That takes a little bit of time, but in some of our cases that may be an issue, and you already kind of know what those impacts are on the pressure line or the pressure waveform. Decreased circulation distal to the insertion site. We've talked about the benefit of the radial artery when it comes to that. And then dampened waveform due to the position of extremity, kinking, as well as infection. Okay. So in we want to level, zero, and calibrate each time the patient is moved. That presents an interesting conversation. Dr. Seidel, can you tell me a little bit about how you handled this in any of the transports that you've done previously?
I'm sorry, can you repeat the question?
When we talk about level zeroing and calibrating our pressure lines each time the patient is moved, how did you manage that?
Honestly, we just, so whenever I flew with my ECCN, we kind of pre-designated roles. And so whenever we noticed whoever was on that side, we would either remind each other to do it, or we would it was just kind of a part of our processes. We did, anytime, especially like if we knew our flight routes, we were pretty good about, asking or have the pilots tell us like when we're at our certain altitudes, if we came down or up, or if there was any movement for any reason, just so we could, again, monitor the lines and re-zero if we needed to.
Okay. So when we talk about or doing the level zero calibration each time the patient is moved, this can get a little cumbersome. You talk about, okay, we've rolled the patient. Now we've got to do it again. We've moved from the roll 2 to the aircraft. Now we have to do it again. Oh, we're at altitude. We got to do it again. Oh, we did an assessment. We had to move the patient. We got to do it again. That can cause you to spend a lot of time doing something that is time away from doing an actual assessment, providing an intervention. So a good rule of thumb is going to be to level zero calibrate before you leave your roll 2. Potentially once you get to the aircraft and are settled. However, once you get to altitude, it really needs to happen. So at a minimum, what I'm going to look for is that you do it when you first do your first assessment, when you get to aircraft, and then when you are at altitude. And again, this is going to be situation dependent, but that's going to be kind of a good approach for that. Now, if it comes out, we're going to follow the mnemonic DPO, okay? Dress the site, provide pressure, and observe the patient. Now, it says that it should be maintained for at least 5 minutes for an arterial line. Yeah, that's going to be dependent on your patient. We've also talked about prophylactic tourniquet placement, which Mr. Dipple will get into a little bit later. As we're packaging that patient, if we have some of these lines, we may want to place a tourniquet. Now, when I say place a tourniquet, I do not mean turn the windlass, get it cranked down, and stop flow. What I mean is putting it on, making sure that it is snug, but not turning that windlass so that in the event that we need it, we can go ahead and utilize it at that time. Now, with any of the interventions that we are doing, it's going to be critical that we follow a very specific assessment path. With that, we very much need to start with our patient, okay? What we're going to call that the mnemonic or that path is going to be man to machine. Our patient assessment is the most important thing that we can do to determine what's going on. After we have assessed our patient, we can move backwards back to the machine. What we tend to see, especially for those that are new to the en route care environment, is that we get so focused on a piece of machinery or technology that we forget about our patient. You're never going to go wrong starting with your patient and working back to that piece of equipment. All right, before I go on, does anybody have any questions about art lines or invasive pressure monitoring? Okay, hearing none, we're going to move on to ELOB, and this is going to allow us to have a conversation about central venous pressure monitoring system, or central. Now, Captain Schuler, talk to me a little bit about why you may want a central line.
Central lines, you're able to give more medications without damaging the vessels. So, like you can give Levofed or norepinephrine or epinephrine. You can give potassium, and none of these will possibly injure the vein wall. You can monitor CVP with the central line. It's a great access if you don't have arterial, so you can actually draw blood from that as well. You can give mass infusions through it. It's just basically like a big funnel.
I love that. Now, Captain Wang, can you tell me what is the unique feature that makes a central line be categorized as such?
The placement of it, like the fact that it sits directly, like a central line goes all the way up and follows directly all the way and sits. My memory not being.
No, you're doing good. Keep talking it out. You're doing great. Keep talking it out.
Kind of like at the top of the atrial valve, the top. Oh my gosh. Ooh.
That's okay. I'm going to help you out because you're
atrium.
Totally
yep.
dead on there.
It's right at the top of the atrium.
Okay, exactly. So when we talk about a central line versus a peripheral line, the tip of that catheter is going to be somewhere not centrally located. So we can have a peripheral IV line, that catheter is only going to be about this long, and it's going to stay out here somewhere in the periphery. The unique piece about a central line is that the end of that catheter, or that tip of that catheter, is right outside our right atrium in our vena cava. Okay. Now with this, that is the piece or part that makes it unique. So it's not necessarily that I put it in a neck or I put it up here in my subclavian or I've got it out here, because we can certainly have peripherally inserted central catheters, right? So it's all about where the tip of that catheter is. And as Captain Schuler mentioned, they give us the opportunity to do a lot of things. I love these because with these I can have double lumen, triple lumen lines that allow me to do various different things through the different ports. For those of you that need a little bit of a refresher, that central line, when I have those 3 ports, those 3 ports act as 3 separate lines. So if I'm going to give a medication in one and a medication in the other, and those 2 can't be mixed, that's totally fine, because there are different lumens within that line that prevent the mixing of those fluids or those medications in the line itself. With this as well, though, there's a little bit of a word of caution in that if I have the central line and it is removed, it's pulled out, well, guess what? I lost all of that access. So it's one site, multiple lumens, but we need to protect it as such. All right, so I put this here, and I want to show this to you guys, not because I want you to be experts necessarily in waveforms for central line. So a normal CVP or central line is going to give me kind of a waveform that looks like this if the tip of the catheter is sitting out here outside that right atrium. Now, if for some reason we do have a waveform that looks a little bit different, we need to start having a concern about the tip of the catheter ending up over here in the right. Now, here's the deal with that. Your cardiac tissue doesn't like to be poked. Okay, it's kind of like me in the morning. I don't like to be poked either. Okay, so if we start to see a difference in the waveform than what we see here on our screen, we need to start looking to see if potentially that line has been advanced. If the cardiac tissue is being poked, we have a greater risk of having ectopy, and with that ectopy, we can have some lethal arrhythmias. So having an understanding of what that baseline waveform looks like, that we can assess for any changes, is critical. Okay, we've talked about this just a little bit. We use these to monitor blood volume, to monitor end diastolic pressure, central venous return, IV meds, fluid, blood. Now, with this, it is rare that we will necessarily be monitoring the pressure of a central line in our environment. You are only going to have so many ports available to you, and if I have, for instance, a head injury patient that needs ICP monitoring and an art line, I'm probably really not going to be ultra worried about CVP. Even in a fixed facility, the use of CVP to guide us for fluid resuscitation has come out of vogue. There's a lot of research that suggests we have better methods to utilize to assess fluid resuscitation needs and response, and we can get into that with things such as stroke volume. So just kind of keep that in mind. Captain Rosales, do you know what a normal CVP is?
I'm thinking it's 1 to 2. I'm not sure if that's right.
That's okay. Here we go. We're looking for 2 to 6 for this. Okay, so it's definitely much lower. Okay, for Sergeant Dumont, if a line comes dislodged during flight, what should you do?
Well, if I'd had my prophylactic tourniquets, I would go ahead and crank down the tourniquet, because then that takes away the set of hands I would need to put the pressure.
Okay, what else? Anything? Do you remember the mnemonic that we had?
Dress the site.
Okay, so DPO. So when we talk about that, we want to dress the site, provide direct pressure, and observe the patient. Certainly, the use of the tourniquet to take the place of the pressure certainly works. We still need to dress that site, though, and observe for that patient's response. And then when we do that assessment, we need to be considering that man-to-machine approach, in that we're going to assess the patient first and worry about the piece of equipment later. Remember, we want to reinforce your central access with additional tape as able to protect your access during patient movement. Now, with this, I also recommend looking to see if the line has been sutured in. Same thing with an art line, because guys, if they need these interventions, they probably need to keep them. Now, we are going to move on here to end-tidal CO2, which I think is the best thing since sliced bread that's happened in the course of my career, but I'm going to pause for just a second to make sure nobody has any questions about central lines. All right, hearing none, let's talk about end-tidal. Now, end-tidal is going to give us an idea of what the alveolar carbon dioxide measurement is at the end of exhalation. Captain Killen, is there a lot of CO2 in the air that we breathe normally?
Thank goodness not a whole lot, unless you're living in Los Angeles.
I mean, that's a fair point, but when we talk about kind of the makeup of our atmosphere, there's not a whole lot of CO2 there. So we are able to use that factor to really measure the CO2 at the end of exhalation and be comfortable with the fact that whatever we're measuring is probably coming from the patient. Now, it gives us an idea of a patient's ventilatory status. Now, we typically default to saying that the end-tidal is 35 to 45, but we need to be cautious with this. The normal PaCO2 is actually 35 to 45 millimeters of mercury, and end-tidal is going to average 2 to 5 millimeters of mercury less than that PaCO2 in individuals with the normal VQ match. Now, I need to bring up a word of caution here. If you have an end-tidal that is, let's say, 38, that means that your PaCO2 is at least 38, but it could be a number that is significantly higher. That number is going to depend on having a normal VQ match. So we have to be cautious when we treat what we see in an end-tidal CO2 because it could be leading you down a path that is erroneous, okay? So keep that in mind, that correlation of 2 to 5 less is only when we have a normal VQ match, so a ventilation and perfusion match. So looking here, we have our nice little waveform, and we're going to kind of do some orientation here. This is the CO2 level, and this is time, and we're going to look at our breath. So as we breathe in, we're breathing fresh air past that sensor. It's going to bring us down to zero because there can be a whole lot of CO2 in the environment. As we start to exhale, you'll start to see that our waveform will climb. And then at the end of our exhalation, we should have the peak amount of CO2 in our environment or past that sensor, and that's where we're going to get our measurement. So as we have that plateau, at the end of the plateau, that's where we're going to get that end-tidal measurement from. Now, the main use of end-tidal CO2 monitoring in critical care is to determine the adequacy of ventilation in the patient supported by ventilation. Captain Battles, can you give me another example of when end-tidal CO2 is potentially used?
We use it frequently when we're giving narcotics.
Okay. What about in the trauma or critically ill patient setting? Sorry, Yanez, can you help her out?
You mean like, well, I guess this one goes into like ACL, like return of like ROS. That's one way to define about it.
Exactly. So we will look to make sure that during our COVID situation, we want that end-tidal hooked up and monitoring, because if we all of a sudden see a bump in end-tidal CO2 where we had very little to begin with, it gives us a hint that the patient has had that return of spontaneous circulation. Now, I say that to say this. If you start to see end-tidal trending down, you probably need to really get on your game because something bad is about to happen. Where we look for that bump up, if we all of a sudden have a bump down, it may be the first indication that something bad is going to happen. So we need to kind of keep that in mind. Acute increase in PaCO2 may occur in patients who are unable to increase their ventilation, and so we would see that in our end-tidal. And it also provides us a continuous assessment of when the patient with controlled hypocapnia is being assessed for that patient with or decreased intracranial pressure, or as a measure to decrease intracranial pressure. We've talked about that recently, and I know we had a little bit of a discussion about that earlier this week about using our ability to manipulate the end-tidal to manage that patient with a head injury, particularly in light of those with signs of pending herniation. Now, another thing that I want to point out to you guys is something called a curare cleft. What you'll notice here is that we have a plateau, and then all of a sudden there's a little dip. Well, as we reviewed earlier, when our waveform is turning, or again, attempting to return to baseline, that's because air in our environment is being drawn past that sensor. So in this instance, this patient is trying to take a breath. What this is a indicator of is that our paralytic has started to wear off, and that the patient is also triggering, and so the patient is triggering their own breaths. This is an indication that we may potentially need to redose our paralytic and reassess for sedation and pain control. Now, for the patient, the depth of the cleft that we see here is going to be directly proportional to how deep a breath the patient is trying to take. Now, unique to each patient will be where on this plateau this cleft is. It may happen here, it may happen here, it may happen here. So it's going to vary by patient, but in general, for the patient, it will happen in the same location. Okay. Before I move on to the scary of scaries with intracranial pressure monitoring, do I have any questions about end-tidal? All right, great. Let's go ahead and move into intracranial pressure monitoring. All right, Captain Schuler, I think earlier this week you were telling us a little bit about you being a neuronurse. Tell me a little bit about use of the Codman catheter and any kind of words or wisdoms or experience that you've had with it.
Yes, ma'am. Good thing about it is, yes, you can. If you get too much cranial pressure, you'll get specific orders if you have to do actual drainage. Unlike the other, you actually have to level this one to the intercanter of the ear instead of the phlebistotic axis of the chest. This one here, and I know they just changed it recently, and what makes it confusing, there's like millimeter to mercury, and there's also the water. So you have to make sure what the order is written for, what you're going to be leveling this device to. I believe at BAMC it's water, not mercury, so you have to double check on that. But every hour they'll put like an order, say, hey, we need to drain no more than 10 mLs an hour. So you actually have to monitor it. Once you actually hit the 10 mLs, you have to actually turn the valve off so that the patient's not draining more ICP or any more fluid out. Because I've seen people where they're not paying attention, they left it open and the patient drained like almost 30 mLs in that hour. And then, of course, things started going downhill fast. Sure. Now, he mentioned a piece about millimeters of mercury versus centimeters of water, and what you'll notice on this common catheter is you have and I know that this picture is a little bit hard for you guys to see, but you'll notice there's a scale right here in blue, and there's a scale right here in green, and that represents the two. So as he mentioned, you really do have to look at what we're using our measurement for. Now, the benefit of having this device is that it does give us some real-time information about what the patient's ICP is doing. And it's going to allow us to have another piece of information to go into our full patient assessment so that we can deliver intervention. Now, I want to caution you because you should not use just this piece of equipment or just this data point to do interventions. Again, you want to look at your whole patient assessment. But there is a little bit of a caution with this as well, in that this can cause some damage to our patient if we are not monitoring effectively. So if I drop the transducer on the floor, all of a sudden I've got all of this outflow, it can actually cause hemorrhage in the brain because we've pulled off too much CSF with this. Gratefully, it's not generally used from roll 2 to roll 3, so we shouldn't see it a whole lot. However, it is present here so that we can just bring it to light and have a little bit of a conversation with it. Now, if you have never cared for a patient with intracranial monitoring or with a Codman catheter, I strongly encourage you to have a conversation with the provider that you're receiving handoff from prior to departure. They are more than happy to give you a quick down and dirty on how to utilize the equipment if you haven't seen it in a while and you need a refresher. With everything in this environment, guys, if you're uncomfortable or you have questions, please do not let your ego get in the way. Your ego is an impediment to providing the best care to your patient, and we've really got to get past that. It is okay to say, hey, I need a little bit of information. Can you show me how this works? Okay, so as Captain Schuler mentioned, we do have a little bit of a different reference point. Now, for this, what you'll see here is that we are going to level that transducer to the tragus of the ear. Now, I have also seen where we look for a midpoint between the outer canthus and the tragus. It doesn't really matter as long as we are consistent with this. There's not a right or wrong, but consistently I have seen that we are going to use this tragus here at the ear for monitoring. Now, with this, we can clamp it to drainage and still get an intracranial monitoring reading. This is a conversation that I want you to have with your provider before you leave the roll 2 if this device is being utilized. If we are able to clamp it, it will allow us to prevent any challenges from draining too much fluid in the events of the device getting bumped around or having a rough flight. So it's something to think about. It's a conversation to be had. If the provider says, you know what, no, you just need to be careful, I need it open the whole time and set appropriately, that's a challenge that we have to work through. But with this, again, do not use an ICP reading alone to make a decision on how you're going to care for your patient. Use the patient's collective assessment in order to determine what your next step is. Now, with this, I do not intend to make you an expert at reading intracranial monitoring waveforms. We do have different parts to our waveform, P1, P2, P3. And what I want you to notice here is that in an abnormal waveform, we have a high P2. Now, this is a tidal wave.
I can't think of a single time in the history of ever that a tidal wave has been a good thing. Okay? So if you do see this portion of your waveform that is larger than the rest of your waveform, we need to start having a conversation about what's going on with our patient. We're starting to see decreased compliance, and we're starting to have bad days forming for our patient. Captain Schuler, have you ever seen a waveform that looks like this?
No, thank goodness.
These are scary. Like, this device in general is scary, but to see this, you start going, fly faster. Let's go. We got to get out of here. Okay, we need to get them to that definitive care or that next level of care at that role 3 at this point. Okay. Other than ICP, what assessment should we use to evaluate neurological status or compromise? Captain Rosales.
That would be your assessment of your Glasgow Coma Scale and your pupils response.
Absolutely. Sergeant Dumont, what else should we be looking for the neurological status or compromise?
Changes to the vital signs.
Specifically what for me?
The your pulse pressure.
Okay. Yeah, exactly. So we might be looking for a widened pulse pressure or a change to our pulse pressure as well as potentially bradycardia. Now, when we have this, we've talked about these, the pupil exam, GCS, and Cushing's reflex. Let's see. Major Rose, can you tell me what the normal value is for an ICP?
I'm going to phone a friend. Hillary Battles, help me out.
It's going to be less than 15.
Okay, so let's just put this up. We're looking at 4 to 15. We really start getting concerned when we start hitting about numbers that look like 20 and 22, for sure. Okay, what's a normal CPP, Major Manzo?
Normal CPP is 60 to 80.
Okay, so here we go. We talk about CPP, just as a refresher, we're talking about cerebral perfusion pressure. Just like we get a MAP, or an ICP, or any of these other pieces, we can also calculate a CPP. Now, with this CPP, we're going to take our mean arterial pressure, we're going to subtract the ICP, and then we're going to get that CPP. That CPP of 60 to 80 allows us to have confidence that the structures within our cranial vault are actually getting. Captain Angelotti, if the catheter for an intracranial monitoring device is accidentally dislodged in flight, what do you do?
Ma'am, I would use the DPO, which is the dress the site, put pressure, and then observe the patient.
Absolutely. I would be a little bit cautious with the pressure piece on this one, particularly given some of the wounds that our patients can have with this. The big things are obviously going to be dressing the site, observing the patient, and going, okay, what was my baseline assessment to begin with? Because now I really have no other information about my patient that would tell me what's going on. And then certainly, Sergeant Yanez, when we do our assessment, what's our approach to doing an assessment?
Man to machine, ma'am?
Absolutely. So it all goes back to our patient. Assess your patient, assess your patient, assess your patient. That's where you're going to get that best information. All right. We're going to move on to ELOE, the management of intra-abdominal pressure. Before I move on, I'm going to pause for just a second to make sure there aren't any questions on the intracranial monitoring.
Ma'am, I have a question. On the ICPs, you said it's not really too much on the roll 1, roll 2s, but I know at the hospitals we actually had to basically take apart part of the A line so that we had that little electrical monitoring, and we would attach it to the ICP machine so that we can actually get an electronic reading. Is that something that we have to kind of take apart and put together if we were going to use that so we can actually get a reading on our monitors?
I'm not sure I'm tracking with that common catheter. It will have the tail that you plug into a pressure cable, and that pressure cable is plugged into your monitor. So on your monitor, you will have pressure ports, okay? And those pressure ports are not specific to the source. So whether it's a CVP, an ICP, an abdominal pressure, or an arterial line, you can plug it into that pressure port or on your monitor. It will give you a reading. I'm not sure if that answers your question. I'm not quite sure I follow.
Yes, ma'am, that did, because I guess the ones that we use, they don't actually have the electrical port, so we would have to kind of like take away and rebuild one so it can have an electrical port. So yes, that answered my question. Thank you.
Okay, great. As long as we have, so that piece that you're talking about is that transducer, and so your catheter should come with one, but if not, you do what you got to do. You'll see that a lot of making do with the supplies that you have. But in general, they should come with that transducer that has the pigtail that goes to the pressure cable. All right, guys, let's go ahead and move to our intra-abdominal pressure monitoring. Now, with this, we don't see this as much, but I want you to be prepared for this in the event that you actually do this pressure monitoring. Now, when we talk about the abdomen, we're particularly concerned about intra-abdominal hypertension, and that's going to be defined as a sustained or repeated pathologic elevation of intra-abdominal pressure to more than or equal to 12 meters of mercury. So our belly doesn't have a whole lot of pressure to begin with, and as it begins to increase, we start seeing significant changes. Now, our intra-abdominal hypertension is graded based off of different pressure levels here. So anything over 12, we're starting to see some changes. Now, if that gets significantly higher, we can start having a conversation about abdominal compartment syndrome. Now, what that is going to reflect is that pressure of more than or equal to 20 millimeters of mercury that is also associated with organ dysfunction. Now, it's categorized into several types: primary, secondary, or recurrent. Primary being that there's an issue going on in the belly. Secondary meaning that the issue is coming from somewhere else but impacting our belly. Big things that we're going to see this with is going to be sepsis and burns. So we may have that conversation, particularly in the environments that we're providing care. And then recurrent, meaning that it's going to redevelop. That primary and secondary are the ones that I'm most concerned about. Now, both intra-abdominal hypertension and abdominal compartment syndrome may compromise perfusion to our visceral organs. We talked about that. If the pressure gets high, then we can't allow those little bitty capillary beds to stay open and provide the delivery of oxygen and nutrients to the cells of our tissues. Now, with this, we're going to monitor for this in a very similar way to the way that we did CPP in our abdominal perfusion pressure, or APP. Now, APP is going to be the MAP minus intra-abdominal pressure. Hang on one second. And it's going to be, we need to really maintain that at more than 50 to 60 millimeters of mercury to ensure that our abdominal organs are actually being perfused. Now, the way that we get after this is through the use of bladder pressure. And that bladder pressure is going to take our indwelling urinary catheter and use it as our reservoir to see what's going on in our abdomen. Now, in general, when we talk about this, our bladder itself doesn't have a whole lot of pressure. It's got even less than our belly. And at times, it can even be subatmospheric. That's why it's a good use. Now, when we do this, we have that transducer. We certainly have to find our reference point. And with this, we're going to use that iliac crest at the mid-axillary line. Now, what you'll notice here is the patient is laying flat. They're at different degrees. I will tell you that because of the shifting of our internal organs, laying flat is going to be that standard. However, if your patient is sitting up because of concerns with ventilator-associated pneumonia, aspiration, or ICP, as long as we are having the same elevation of the head, it's going to be fine because it gives us the same type of number. Now, when we talk about this setup, Captain Wynn, have you ever done abdominal pressure monitoring?
We don't do a lot of it in the ER, to be honest. I've done a couple of shifts. When I did a couple of shifts at the ISR in San Antonio, they had a lot of these, and so I got to kind of like work with them a little bit there and kind of looking at the pressure monitoring, the bladder pressure and stuff, but not multiple days of it, just a couple shifts.
Okay, so let's talk through this a little bit. Guys, if your patient has a Foley catheter that has a port somewhere on the catheter, you can get after this. Now, there are commercial devices that are already set up and ready to go. Now, for this one, this does not need to be set up under a pressure bag at all. And in fact, you're probably going to need a significant amount of fluid to infuse if you're doing these regularly. So what you're going to do is you're going to infuse about 25 cc's of normal saline into the bladder. Once you do that, you're going to clamp off the Foley catheter from draining, and you're going to let it sit for about 30 to 60 seconds. At the end of your patient's breath, after they exhale, you're going to get your pressure reading. Once you do that, you'll go ahead and unclamp your Foley catheter catheter and allow the urine and the instilled fluid to flow down into the Foley bag. Now, Captain Killing, can you tell me why we might want to do this at the end of exhalation?
Because it's going to be I'm guessing here, but I think it's probably going to be the most representation of the true pressure inside the abdomen below the diaphragm.
Okay, and why would that be? Why do you think the end of exhalation gives us a better idea of what pressure is going on?
Because the diaphragm is not going to be as tense, and it's going to be more relaxed at the end of exhalation.
Right, so as we breathe in, that diaphragm contracts and it presses down our abdominal contents, which could potentially raise the pressure of our abdomen. But when we exhale, that diaphragm relaxes, and it's going to not have that same effect on the abdominal pressure. So absolutely, at the end of exhalation, that's where we want to get this. Big thing that I notice is that when we do these is that people forget to unclamp the Foley to allow that return of flow. So I just want to caution you with that. And remember, it doesn't take a lot of fluid. In fact, if you're using much more than 25 milliliters of fluid, you're probably setting your patient up to potentially have bladder spasms or something along those lines. So you really don't need a whole lot of fluid. So we have talked today about arterial blood pressure monitoring or invasive blood pressure monitoring, central lines, end tidal, intracranial pressure monitoring, as well as intra-abdominal pressure monitoring. Sergeant Seidel, if you had only 2 pressure cables, which ones would you use to trend if you had all of the devices?
I'd say my my art line.
Okay.
And my end tidal.
Okay. Would that change for you if your patient had a head injury and had a Codman catheter?
If he had a head injury, it'd be great if I had like an ICP monitor and then like an end tidal. But end tidal would kind of work for both because you can kind of see, you can still, an art line would still work because you can at least trend their pulse pressures, their blood pressure, their end tidal, and kind of, you have to do more trending more or less to see the patterns and kind of keep an eye on like what you think might happen. But an ICP would be, obviously the best.
Right, and with this, I think you can actually get away with all 3 because for that end tidal, the port that you're going to connect to or the way that that's going to be monitored is not off of a pressure cable. So you could still have your intracranial pressure monitoring, your art line, and your end tidal in that scenario. For me, guys, it's really just going to depend on my patient status and what I have before me. If I have a patient that is sick enough to warrant the invasive line of intracranial pressure monitoring, I'm going to want to use that. And then that needs to go with my art line so that I can get a CPP. But certainly we can do spot checks for other things if it really becomes clinically warranted. All right, guys, at this time, are there any questions on the presentation from today?